In this lecture, I'll be covering GI bleeds. Here are the learning objectives along with recommended reading. I would also highly recommend that you go back and review prior lectures on GI bleeds to get a further understanding if you're unclear on this topic. So just to review some of the basic terms I'm sure you guys are already familiar with, but hematemesis is vomiting up blood. If it's gross blood, that indicates significant bleeding, whereas if it's coffee ground, it's more digested blood, so it's not bleeding as briskly. Melena is the black stool, that's stool with partially digested blood, and it indicates blood has been present in the GI tract for about 14 hours. Hematochezia is bright red blood per rectum and is usually of lower GI bleed origin, but it can also be upper if the bleeding is brisk enough. This is usually considered greater than 60 mLs per hour. And then occult bleeding is bleeding that's not apparent to the patient. This is where you get a hemoccult to further define. So I hope none of you are eating right now. If you are, you can stop, but I just wanted to show some pictures. But upper left, this is gross hematemesis. This is more coffee ground emesis. And then this is melena, that black stool that's soft. And then this is hematochezia. So as far as epidemiology goes, upper GI bleeds are 4 times more common than lower GI bleeds. So this is what you're primarily going to see in the hospital. It also affects male to females at a 2-to-1 ratio. Obviously, it would affect old people over young people. And the mortality rate is about 5 to 11%. Upper GI bleeds have a higher mortality than lower GI bleeds. And 80 to 90% of lower GI bleeds actually stop spontaneously. However, 25% will re-bleed during or after the hospital admission. So you really have to determine what the underlying cause is and stop it so that it doesn't come right back when they're discharged home. So now I'll discuss upper GI bleeding. The ligament of Treitz is the anatomical location that differentiates an upper from a lower GI bleed, which is basically the junction of the duodenum and the jejunum. Just to confuse matters, it's called a ligament, but it's actually skeletal muscle. So the first step in the evaluation of an upper GI bleed is risk assessment. This is done by reviewing their vitals and their risk factors. So reviewing their vitals, obviously you want to look at their heart rate and their blood pressure. If those are low, if their heart rate's high and their blood pressure's low, that could indicate a more significant bleed. Also the risk factors. For instance, are they greater than 60 where you might suspect more of a lower GI bleed or angiodysplasia or cancer, whereas middle-aged people typically suffer from more peptic ulcers, varices, and esophagitis. Have they had any previous bleeding where you might suspect the same cause? Do they have any underlying liver disease, such as esophageal, that could indicate like esophageal or gastric varices? Were they retching, such as intractable nausea, vomiting with gastroparesis or cyclic vomiting syndrome that might lead you to believe they have a Mallory-Weiss tear? Or is it non-GI sources, such as, those pseudo-GI bleed, where it's actually coming from the nasopharynx, like they've got epistaxis that ran down and then they vomited it up. So the Glasgow-Blatchford bleeding score is a scoring system that's used to risk stratify upper GI bleeds who are low risk. You do not need to memorize this. Honestly, I have never even used this scoring system, but I am familiar with it and I keep it in the back of my mind. It basically helps determine whether a patient can be worked up or should be worked up inpatient versus if they could go home. It's calculated using several different lab scores, primarily the BUN, hemoglobin, systolic blood pressure, heart rate, and then symptoms. It's kind of like the CURB 65 score for pneumonia. So when you're assessing the severity of the bleed, you need to determine whether it's considered minor, moderate, or severe. So if it's a minor bleed, they'll typically have normal vitals, and this indicates that they've lost less than 10% of their blood supply. Whereas if it's moderate, this is when you'll start seeing orthostasis, and they've lost 10 to 20%. And then if they're having shock or resting hypotension, you know they've lost up to 25% of their total blood supply. So the management of upper GI bleeds involves placing first 2 large bore IVs. This is considered over 20 gauge IVs, preferably 18 gauge. And then you want to give IV fluids. But remember, this is going to drop the hemoglobin even more because it dilutes it out. And then packed red blood cells. You want to give these if the hemoglobin is less than 7, if they're hemodynamically stable and they don't have heart disease. However, if they have hypotension or heart disease, then you can transfuse before the hemoglobin actually reaches 7. So just to give a little example here, so you've got Mr. Simpson who presented to the ER with hematemesis times 1 episode. His past medical history includes hypertension, coronary artery disease, and his home medications include Norvasc, aspirin, and Lipitor. His vitals are his heart rate is 101, respiratory rate 18, blood pressure you can see is a little bit low, he's afebrile, and he's not hypoxic, but his hemoglobin is 7.5. So are you going to transfuse this patient? So I would say yes at this point, especially if I'm suspecting an upper GI bleed, because he's got underlying coronary artery disease and he's nearing 7. However, I also want to look at his baseline hemoglobin. If his baseline is around 12 and now he's 7.5, that indicates he's lost quite a bit of blood. So I'd be more apprehensive or responsive in giving him blood at that point. However, if his baseline's, around 7.5 or 8, then I might hold off a little while and trend the hemoglobins every 2 to 4 hours and see what happens. So also on this patient, I would place 2 large bore IVs. And then we know from Mr. Simpson's history that he's an alcoholic. He hurts himself all the time, so he likely takes NSAIDs on top of his already prescribed aspirin. So I'd probably start the patient on an IV PPI drip along with an octreotide drip. I'd also monitor his hemoglobins and vital signs closely. So I just wanted to add a side note about hemoglobin and hematocrit. So remember, hematocrit is a volume level, whereas hemoglobin is a concentration. If the total volume goes down, it is not going to change the hematocrit very much. So you can see from this picture that the hematocrit doesn't really change much until 1 to 3 days after the bleeding has occurred. Honestly, we used to get serial H&Hs, or hemoglobin and hematocrits on patients, but it is just a waste of money to get the hematocrit, so now we just do serial hemoglobins. So the lab evaluation of upper GI bleeds, typically you'll see an elevated BUN because blood is broken down, the blood protein is broken down to urea. So typically you'll see a BUN to creatinine greater than 36. This is highly suggestive of an upper GI bleed. So if you see the BUN and it's actually low or normal, then you might be less suspicious that the patient has acute bleeding. Perhaps they bled a day or 2 before and they're just passing the blood in their stool. But if you see that BUN trending up or really high, that's a lot more indicative of an acute bleed. Also, do they have a low MCV? This indicates microcytic anemia, which could indicate iron deficiency anemia. Are they hypokalemic, such as if they've got nausea, vomiting, or diarrhea? You may see hypernatremia due to dehydration, which you treat with IV fluids, but that's further going to drop their hemoglobin, so you might need to watch them closer on serial hemoglobins to give them blood if they need it. And then do they have any leukocytosis or hyperglycemia indicating a stress reaction? You also might want to get coagulation studies such as PT-INR and APTT, especially if they're on Coumadin or heparin. The most common causes include ulcers, followed by gastropathy and erosions, then varices, Mallory-Weiss tears, and esophagitis. There are other less common causes, but the one you really don't want to miss is an aortic graft fistula. Honestly, I've never seen it, but I always make sure the patient has not recently had an aortic aneurysm repair, as this is very lethal. Approximately 50% of patients die even with the surgery. So you need a CT angiogram to further diagnose this. Peptic ulcers are the most common cause of upper GI bleeding. It primarily involves the lesser curvature of the stomach or the duodenal bulb. 80% are self-limited, meaning they stop bleeding without any treatment. This doesn't mean you don't need to get GI to see them for a scope, because they may start rebleeding. The causes include NSAIDs and H. pylori as the primary culprits, but others include bisphosphonates, cirrhosis, anticoagulants, and alcohol. Remember remember that prostaglandins protect the stomach mucosa by stimulating mucus and bicarb. NSAIDs suppress prostaglandins, therefore you get decreased mucus and bicarbonate, which raises the stomach pH, causing the ulcers. H. pylori contains urease, which is the enzyme that cleaves urea into ammonia, which produces ammonia. Ammonia is very alkaline. It's used to protect itself from the acidic stomach. With all of this ammonia, the stomach senses that the pH is going up, so you secrete more acid to compensate for this, which leads to the ulcer formation. Esophageal varices are basically varicose veins of your stomach and your esophagus, and it's caused by cirrhotic liver, which increases portal hypertension, which causes stress on those veins, causes them to dilate, and sometimes they can bleed. So as far as management goes for upper GI bleeds, if a patient is on an anticoagulant, you need to weigh the risk versus benefit of continuing them. Most of the time you just hold them and they rarely require reversal. However, you should know how to reverse them if necessary. Coumadin can be reversed with vitamin K and FFP. Factor Xa inhibitors such as Xarelto and Eliquis can be reversed with Kcentra, which is a 4-factor prothrombin complex concentrate, and it costs around $5,000 per dose. Pradaxa can be reversed using the direct thrombin inhibitor Praxbind, which costs around $3,500 per dose. Heparin can be reversed with protamine sulfate, and low molecular weight heparin, or Lovenox, has really no specific reversal agent, but protamine has some effectiveness and can be given. Now for antiplatelets, aspirin is, as far as aspirin goes, if a patient is on aspirin, you should know whether it is for primary prophylaxis or for secondary prophylaxis, and only use it if the benefit outweighs the risk. So primary is used to decrease the chance of getting the disease, whereas secondary is used to prevent recurrence of the disease. So say the patient has coronary artery disease or a stroke, that is secondary prophylaxis. Usually for primary prophylaxis, you can discontinue it, whereas for secondary prophylaxis, you usually DC it for 3 days, then you restart it once hemostasis is secured. Other antiplatelet drugs include Plavix, Effient, Brilinta, and usually with these you'll need to notify the patient's cardiologist that the patient has a GI bleed and determine if it is safe to hold it or not. Don't ever just assume it's okay to hold it. For instance, let's say a patient with a recent high-risk drug-eluting stent may not be able to hold the antiplatelet, as you may stop the bleed, but then they die from restenosis of their new stent. So this is why you really need the cardiologist's input. So let's go through another example. Let's say you have an 86-year-old female who presents to the ED with coffee ground emesis ×3. She has a history of aortic stenosis, status post-mechanical aortic valve replacement. She is on Coumadin. Her hemoglobin is 6.3 and INR is 8. So if you remember, mechanical aortic valve, the INR should be 2 to 3, and for mitral valve, it should be 2.5 to 3.5 because it's a lower pressure valve, so it requires a higher INR. So what are you going to do and why? So you usually cannot just stop the anticoagulant, as the patient will form a clot on the mechanical valve and cause a stroke. This is a time when it is important to get GI on board right away for endoscopy to get the bleeding under control so that you can resume their anticoagulant as soon as possible. Oftentimes you just have to keep giving them blood as needed before their hemoglobin level drops. Now let's say you have a 52-year-old male with a history of coronary artery disease, status post-LAD stent 2 years ago, hypertension, hyperlipidemia, and COPD, who presents to the ED with hematemesis. Meds include Norvasc, hydrochlorothiazide, metoprolol, pravastatin, aspirin, albuterol, and Spiriva. Vitals reveal heart rate of 98, respiratory rate 18, blood pressure 112/76, 94% on 2 liters nasal cannula, and the hemoglobin's 9.2. However, the previous hemoglobin was 14.2, and his coags are normal. So, how are you going to treat this patient? So I would first start out, I would make sure that I started 2 large bore IVs. You need to give IV fluids since the patient's blood pressure is borderline low. You probably need to, would you transfuse the patient? So obviously with his coronary artery disease and his hemoglobin less than 7, you would definitely give at least a unit of blood and then trim their H and H's. And then what about the aspirin? So since he is 2 years out from his stent, he is safe to hold his aspirin because he's, right now he's taking now for primary prophylaxis rather than secondary prophylaxis. You'd hold it at least until the GI bleed is found and repaired. So then you'd probably, hold it for 3 days. You may get cardiology's input, but then once hemostasis is controlled, then you would restart it, watch their hemoglobin, see what happens, send them home the next day if their hemoglobin's stable. So as far as the pharmacologic treatment of upper GI bleeds, if the patient has peptic ulcer disease, you'd want to start a PPI. If the patient's not actively bleeding, there's no need for IV, just use PO. Also, no evidence that higher dose is any more beneficial than lower dose. There's also no evidence showing that a drip is more or less beneficial than IV BID, and BID dosing usually is cheaper, so this is more typically done. There's no study showing one PPI more beneficial than the other, so it's really based on what is on formulary at the hospital that you're at. Now, if the patient has underlying liver disease, this is when you'd want to consider starting them on an octreotide drip. Octreotide is a vasoactive med that decreases portal blood flow. It's typically given as a 50 microgram IV bolus, then 50 mics per hour times 2 to 5 days. And this is all dependent on what the gastroenterologist finds on the endoscopy. Other medications that may be considered, sucralfate or Carafate, promotes ulcer healing by improving mucosal repair. It might decrease acid and suppress H. pylori infection, and it may provide protection from NSAIDs. Also misoprostol, which is a prostaglandin analog. It's usually limited by abdominal side effects, but may protect against NSAIDs. Honestly, I rarely see that used. Another option is bismuth salts. This is also rarely used. It may increase mucosal prostaglandin synthesis. Sometimes it's used as an extra agent in H. pylori treatment, though. So endoscopy is basically used to determine the cause and to risk stratify the patient. There's lots of different treatment options available to the gastroenterologist, and this is dependent on what they're comfortable with and what they feel will be the most effective. These treatments include epinephrine injections, monopolar coagulation, bipolar coagulation, heater probe, hemoclips, argon plasma coagulation, and honestly, the GI docs that I've talked to, it's all dependent on what they're most comfortable with. A lot of them work fairly similar, and I'm not sure that there's any studies showing one superior to the other, but I may be wrong on that. And then if endoscopy fails, this is when you'd want to consult surgery or interventional radiology. This is if they've got, a perforation or uncontrolled bleeding. And as far as post-endoscopic care, when hemostasis is secured, it's okay to restart their antithrombotic agent while continuing the high-dose oral PPI BID. And I should have put this in there, but as long as the GI doctor is okay with it. If the GI doctor says, no, you need to hold it for 3 days or 5 days, whatever, you need to follow their instructions, obviously. And just to rehash esophageal varices treatment, it's a combo of pharmacologic and endoscopic treatment. So pharmacologic, as I had mentioned, the octreotide drip to decrease portal hypertension. Transfusions, overtransfusion can cause rebleeding, which would increase portal hypertension. So you need to remember that and only give them blood if it's absolutely necessary. Oftentimes we'll use non-selective beta blockers as secondary prophylaxis. These you can increase as tolerated to obtain a resting heart rate of 55 to 60. And then infection prophylaxis for all patients. So these patients are at higher risk for SBP, so you need to treat for that. So you give them Rocephin 1 gram IV daily and transition that to Cipro and complete 7-day course. Endoscopically, they typically use band ligation. That's usually the treatment of choice. However, some use sclerotherapy also to maintain the esophageal varices to stop the bleeding. And then if it's gastric, a lot of times they'll use obturation with cyanocrylate. Another treatment for esophageal varices is what's called a TIPS procedure. It stands for transjugular intrahepatic portosystemic shunt. This procedure is usually a last-ditch option for patients with recurrent esophageal variceal bleeding. It's usually used if medical and endoscopic treatment fail. And it's usually used with gastric varices over esophageal varices, and it has increased risk of hepatic encephalopathy. So if you remember hepatic encephalopathy, basically your body's not able to break down ammonia. It builds up, it causes encephalopathy. So these patients, you're basically bypassing the liver, so they have no liver to filter out their ammonia. So if you do this procedure on a patient with prior history of hepatic encephalopathy, you're going to highly increase their risk of getting this in the future. So it's just a contraindication. So Mallory-Weiss tears are a tear in the gastric or esophageal mucosa. Typically only makes up 5 to 10% of upper GI bleeds. It's usually accompanied by a history of normal vomiting, so they'll just have vomiting and retching followed by coughing with hematochezia. The prognosis, these typically stop spontaneously in 80 to 90%, but as mentioned with other causes, it doesn't mean that they still don't need a scope. You still need to go in and see if something else is going on. It'll give the endoscopist a chance to get biopsies if necessary, stuff like that. The treatment, they typically only treat it if they're actively bleeding, and it involves injection or banding. Now I'll discuss lower GI bleeding. As with upper GI bleeds, there are lots of different causes of lower GI bleeds also. Diverticular, angiodysplasia, and angioectasia, or AVMs, and post-polypectomy are the most common causes of severe lower GI bleeds, whereas hemorrhoids are the most common cause of minor lower GI bleeds, and they're typically managed as an outpatient. Diverticular bleeds are typically arterial, so you're going to get a lot of blood with these. They're usually painless. If they're painful, they may have concomitant diverticulitis on top of it, which case you'd have to treat the diverticulitis and get the inflammation controlled before you could proceed with endoscopy. They usually occur in the neck or dome of the diverticulum, which you can't really reach with an endoscopic scope. 75% of them actually stop spontaneously. So, like I said, like endoscopy usually really isn't helpful. The vessel usually is inside the thin-walled diverticulum, and they just can't reach it with the scope. It's typically treated with angiography, so this is when you'll get interventional radiology involved or surgery for embolization, or they may have to go in and actually resect that part of the colon out if it's recurrent. Angiodysplasia, which is basically a cluster of blood vessels. These can occur throughout the colon. They're most common in the right side of the colon. Risk factors, these are usually in elderly patients greater than 60 and patients that are on anticoagulants. And post-polypectomy. Bleeding from this can occur immediately or days or even weeks later. So you always have to ask the patient if you're suspecting you just have to ask them if they've had a recent colonoscopy. There's a greater risk of post-op bleeding if the polyp is greater than 2 centimeters. So usually these are at planned endoscopy as an outpatient where the gastroenterologist can take his time and make sure and make sure that they get bleeding well controlled before they end the scope. These also are typically in the right colon and occur once you restart their antithrombotic therapy. Usually requires a repeat colonoscopy, so you have to prep them for it. Another cause is ischemic bowel disease, and there's basically 3 categories of this. First is acute mesenteric ischemia. This is accompanied by an abrupt, severe abdominal pain. So if you have a patient with severe abdominal pain along with hematochezia, that's when you should highly suspect mesenteric ischemia. Lactate may help you, their white count may be elevated, and you'd want to get a CT with contrast to further investigate. It's rare. 15% of them can lead to hematochezia and vasoconstriction in the presence of sepsis or intravascularly depleted. Sorry, what I meant by that last line was vasoconstriction occurs basically in the presence of sepsis or intravascularly depleted. So think of your ICU patient with septic shock, or a patient that's on pressors, or a patient that's really dehydrated that's in the hospital. All of that can precipitate acute mesenteric ischemia. So if the patient develops severe abdominal pain, you've really got to investigate for this and, always consider it. Chronic mesenteric ischemia occurs over months to years and is usually secondary to atherosclerosis. Just like atherosclerosis in your heart or the aorta or any other peripheral blood vessel, you can also get it in your bowel. And then colonic ischemia, this is the most common ischemic bowel disease. It's usually due to non-obstructive low flow state in microvessels, usually in the setting of hypovolemia or hypotension. So it's very similar to mesenteric ischemia, but this obviously doesn't affect the mesentery, it affects the colon. So think of patients that are on pressors in the ICU. They may develop abdominal pain and it's their colon slowly dying. So this would mean that you need to be more urgent in your workup and consult interventional radiology or surgery to help you out. So as far as the workup for lower GI bleeds, it includes a colonoscopy, which is performed within 24 hours. However, you have to remember the patient has to be prepped for it. So, they're going to be up all night pooping and they're going to be dehydrated and tired and hungry. So usually you get cranky patients in the hospital when you have to get a colonoscopy on them. However, it does identify 2/3 of the cause of the bleed. Remember that hematochezia plus hemodynamic instability may still be an upper GI bleed. So, usually 60 mLs per hour will cause hematochezia, and it could still be an upper GI. Now, we've discussed upper GI bleeds and lower GI bleeds. However, there's another small section which is small bowel bleeding. These are a little bit more difficult, well, actually a lot more difficult to diagnose and treat in the hospital, and they can be very frustrating to the patient and the provider, just because they're more diagnostically challenging. So this includes bleeds from the ligament of Treitz to the ileocecal valve. It involves about 5 to 10% of all GI bleeds admitted to the hospital. And the causes, this really isn't all-inclusive and it varies by age, but typically elderly patients, it's due to an AVM, just like that angiodysplasia of the colon. You can also get that in the small bowel, and that's the most common cause. It's usually intermittent, which makes it very difficult to diagnose. They'll bleed 1 hour and then the next hour they'll be fine. So, it's very tricky to try to figure out how or where they're bleeding from. If they're greater than 50, you may need to consider malignancy, so you'd want to get a CAT scan with contrast to further evaluate their small bowel for a mass. This is also concerning if the patient's had any weight loss or if they have concomitant abdominal pain, which can lead to an ileus or bowel obstruction. If they're 20 to 60, you may consider like a Meckel diverticulum. This is typically present on CAT scan. And they could have possible abdominal pain with it. So this should be considered when they have a negative EGD and a negative colonoscopy. So as far as further testing goes, if the patient is stable, then you would want to do a PIL-GAM study. This is also called capsule endoscopy, and it's usually done as an outpatient. In fact, I don't even think it's covered by insurance company to do it as an inpatient. It's used if there's little to no active bleeding. The pros are it's very easy to do. Basically, you just have the patient swallow a pill and it sends pictures. It examines the majority of the small bowel mucosa. However, the cons are that you can't get any tissue sample and you can't do any intervention. So basically, all you can do is find what's bleeding. And it doesn't always reach the cecum during the time frame of the PIL-CAM, so sometimes you can't get the entire small bowel involved. So here's further information as far as the PIL-CAM. So basically you can see from the left upper picture that this small pill, it's got a small camera inside of it. It's swallowed with water after about 12 hours of fasting. You can drink 2 hours later and eat about 4 hours later. It records about 2 to 3 images per second, so around 55,000 images over about 8 to 20 hours. It takes 30 to 90 minutes for the software to review and pick out concerning images that are then reviewed. Then the PIL-CAM basically gets flushed down the toilet, along with around $500, which is how much those pills actually cost. Now, if the patient has unstable GI bleeding from the small bowel, this is more of an inpatient workup, and this is where you would either get a tagged red blood cell scan, also called a bleeding scan, and this detects bleeding at a rate of 0.1 to 0.5 mLs per minute. The only problem is they have to actively be bleeding. So the pros, you can repeat it several times per day. So let's say the patient has a big bloody bowel movement, then you can rush them down to IR and do a tagged RBC. However, sometimes they'll stop bleeding or they'll just be intermittently bleeding. So then you bring them back upstairs and then they have another bleed and send them back down. And I mean, we've done that 2 or 3 times before we actually, send them for IR angiogram to further help characterize and stop the bleeding. So the cons with it, like I said, it requires active bleeding. So you can actually locate the bleeding to the general area. So here's an example of a tagged red blood cell scan. You can see the red blood cells are tagged with nuclear contrast and images are obtained over 30 to 90 minutes, which tell you where the patient is bleeding from. Like I said, it requires active bleeding, and most of these types of bleeds are self-limited and resolve on their own. So also, if the patient's having unstable GI bleeding from the small bowel, you can do a CT abdomen and pelvis with angiography to help further diagnose where it's at, and it detects bleeding rates of 0.3 to 0.5 mLs per hour. The pros, it's very sensitive, it's also very fast and can evaluate for other things going on, such as a tumor in the small bowel or bowel obstruction, ischemia, stuff like that. The cons, though, it does involve radiation. It also involves giving IV contrast, so it can cause nephropathy, and it requires active bleeding. So here are the sources that I used for this presentation. As always, if you have any questions, please post them on the Google Doc. Thank you.